Good morning, dear friends and respected faculty. We are again here on this Sunday morning with the next session on fever with rash. The speaker will be Dr. Rashmi Sarkar. She is the Director Professor at Lady Hardinge Medical College and Kalavati Saran Children's Hospital. And she'll be taking this session on fever with rash. And we have Dr. Arpita Chattopadhyay also. She is a Professor of Pediatrics at Chacha Nehru Bal Chikitsalayah, because this issue, fever with rash, is most commonly a pediatric condition, and she'll be answering many of the questions. And fever with rash being a very common OPD presentation, I think it will be useful for all of us. Thank you very much. I request Dr. Rashmi Sarkar to please begin her presentation. I request all panelists to please switch off their phones. Good morning, dear friends. Dr. Vipul, please request to please start the presentation.
Hello, everyone, and I'm Dr. Rashmi Sarkar. I'm a Director Professor in the Department of Dermatology, Lady Hardinge Medical College, and Associated Kalavati Saran Children's Hospital, New Delhi. And I'm going to talk to you on a very important topic for pediatricians, and that is approach to fever with rash in a child. And obviously, you always take the help of the dermatologist whenever we do this, so it's a dual method of diagnosis. You can also reach me at my email, that is rashmisarkar@gmail.com. Now, when we talk about fever with rash, it's just very important, first of all, to define fever. So, as we know, this is an elevation of the body temperature above the normal range of 36.5 to 37.5 degrees Celsius due to an increase in the hypothalamic set point. Now, the causes are due to pyrogens. These are mainly microbial products or toxins, or they can be whole organisms. Pyrogenic cytokines are produced both during infection and inflammatory process, and it could be interleukin-1, interleukin-6, tumor necrosis factor, ciliary neurotrophic factor, and interferon. Now, we talk about a rash, which is a very common term in dermatology, but how does this occur? This is due to multiplication of the infective organisms in the skin. A very common one that you see is the herpes simplex virus. Toxin produced by organisms acting on skin structures. Autoimmune destruction of the skin due to inflammatory response against the infective microbes, and involvement of the vasculature. So you have vaso-occlusion, necrosis, and vasodilatation. Now, when we take a history, it's important to know what is the age of the child, the duration, onset, was it sudden or gradual? That's important. Like, for example, in a drug rash, that is going to have a temporal correlation, location of the lesion, central or peripheral, as we'll discuss, sequence of distribution of the rash, associated symptoms like itching, pain, and also burning. Temporal relationship of rash and fever, this is very common during drug-induced fever with rash. And finally, presence of similar complaints in close contacts, which shows that it's going to be more infective. Now, an exposure history is also important, whether there was a drug ingestion within the past 60 days, travel outside the local area, because there you come across so many flies, insect bites, and so on. Occupational exposure, sun exposure, Immunizations, sexually transmitted disease exposure, including risk factors for infection with HIV. Exposure to febrile or ill persons within the recent past. Exposure to wild or rural habitats, insect arthropods, and wild animals. You may have gone out on a holiday. You may have gone to the jungles or safari. Exposure to outdoor water sources such as lakes, streams, or oceans. So again, this could be fungal, it could be rickettsial. Pets, animal exposure and habits. And finally, valvular heart disease, including heart valve replacement. So what do you do in the physical examination? Some very simple things which we should not forget, like looking at the vital signs. A general appearance will tell you that is the child too sick? Are there signs of toxicity? Presence of primary lesion or the secondary lesion and its pattern. Presence and location of lymphadenopathy, do not hesitate to do so. Presence and morphology of genital mucosal or conjunctival lesions. Detection of hepatosplenomegaly. Presence of arthritis and signs of CNS involvement like nuchal rigidity, meningismus, or neurological dysfunction. Now, when we classify the rash, what I'm going to do is I'm going to take you through the morphological distinction. Maculopapular eruptions, confluent desquamatic or scaly erythemas, vesiculobullous or pustular eruptions, urticaria-like eruptions, nodular eruptions, purpuric eruptions, and eruptions with ulcers or ishka. So we'll go through common conditions and what is important in our Indian setup. Some of the pictures are, of course, taken from the books and articles. So first of all, a very important one, that is maculopapular eruptions. Now, this is seen mostly in viral illnesses and immune-mediated syndrome. So there are mainly three causes for fever with rash. One is the infective etiology, the immune-mediated syndrome, and the drug-induced one. So these could be centrally distributed, which is common, and it begins centrally and first affects the head and neck and then progresses peripherally. Or it could be peripherally distributed when it begins in the peripheral areas before spreading centripetally. Now, the centrally distributed one, you see these commonly as viral infections like measles, rubella, erythema infectiosum, exanthem subitum, and primary HIV infections, infectious mononucleosis, other viral exanthems like ecovirus 2, 4, 9, 11, 16, and 25, and Kawasaki virus A9, B1, B5, and finally dengue fever. Exanthematous drug-induced eruptions. These could be, some common ones are antibiotics, anticonvulsants, and diuretics. Then, of course, the bacterial ones. Now, many of these are not so common in India. The ones which you commonly see are rheumatic fever and the typhoid fever, which you see in children. Others, like the various kinds of typhus, epidemic, endemic, scrub typhus, leptospirosis, Lyme's disease, and so on. These are seen in other regions. Autoimmune, the common ones would be systemic lupus erythematosus and the Still's disease. Now, what about the peripherally distributed maculopapular rashes? Now, in bacterial, the common one for our setup would be secondary syphilis and bacterial endocarditis. Rocky Mountain spotted fever and bright white fever are not so common. Well, the viral one is something we see in several months in the year, that is the Chikungunya fever and hand, foot, and mouth disease. And of course, erythema multiforme. So when we talk about measles, the salient features is this is by the paramyxovirus. And not only is it common in children, but also in non-immune patients. Of course, the mode of spread is a droplet infection with an incubation period of 10 to 12 days. What we see is an erythematous confluent maculopapular rash, which develops on the 4th day of the fever. Now, this starts behind the ears and the forehead, And when it resolves, there is a brownish discoloration and scaling or desquamation, which fades over the next 10 days. So clinical features are high-grade fever with the three C's, that is cough, coryza, and conjunctivitis. You have malaise. And then, of course, what the pediatricians know best, that is the complex spots, which is again the in the buccal mucosa. And these are things, which will tell you definitely that this is measles. Now, this has a good number of complications like acute otitis media, interstitial pneumonia, myocarditis and pericarditis, encephalitis, subacute sclerosis, panencephalitis, and mesenteric lymphadenitis. Diagnosis is by clinical examination, IgM antibody detection, and viral DNA detection by RT-PCR. Treatment is mainly supportive with adequate hydration. So you can see the conjunctivitis, the macular or the maculopapular rash, and what you identify well, that is the complex spots, because these patients do present to the pediatrician first. Now, rubella. This is, of course, caused by the rubella virus, which is ssRNA toga virus family, and it invades the human respiratory epithelium. This is transmitted by the susceptible contact, and we know that the infection in utero, the congenital rubella syndrome during the first trimester, can be quite an issue. The virus is present in the nasopharyngeal secretions and urine, and period of communicability is contagious from 2 days before until 5 to 7 days after the onset of the rash. So these outbreaks do occur in non-vaccinated groups, especially where there is crowding like the workplaces, prisons, colleges, and healthcare centers. Transplacental antibody protection occurs only during the first 6 months of life. So the incubation period is 14 to 21 days. What you see is a lot of lymphadenopathy, that is retroauricular, posterior cervical, posterior occipital one, and then it evolves into the erythematous, maculopapular. These rashes are discrete. And it begins on the face, spreads down to the body, and lasts for about 3 days. Now, you don't see the complex spot here, but what you see is the Forsheimer's spots, which are rose-colored spots on the soft palate. There is mild pharyngitis, conjunctivitis, anorexia, headache, low-grade fever, and polyarthritis. So this is important to remember. Investigations are non-specific, but you can have a normal or low count of WBC, thrombocytopenia, serological tests like IgM antibody, and fourfold rise in specific IgG antibodies in paired acute and convalescent sera. Now, the complication, definitely it's much less as compared to measles, but in pregnancy, you have the congenital rubella syndrome, and that, of course, is marked by the IUGR, cataracts, deafness, patent ductus arteriosus. So let's have a quick look at the differences between measles and rubella. Both are with fever and rash, but in rubella, the fever is mild or sometimes there's no fever. Of course, you have the confluent macular rash in measles with the complex spot, and somewhat more discrete rash in rubella with Forsheimer's spots. And that, of course, it's by droplet infection in both, but it can also be airborne in measles. Symptoms in measles are the high fever, runny nose, cough, and for 3 to 5 days followed by rash. And here in rubella, it's rash with minimal to no fever or toxicity, and infection is possible even without a rash. Again, the treatment is mainly supportive, and the congenital rubella syndrome baby has to be isolated. So this brings me to erythema infectiosum, or the fifth disease, which is again caused by human parvovirus B19 and spreads by respiratory secretion. So typically children 3 to 12 years of age are involved in spring and winters. What you see is in the picture here, there's a classic bright red facial rash, slapped cheek appearance, which progresses to lacy reticular rash and may wax and wane for 6 to 8 weeks. So there is mild fever, arthritis in adults, and rash after the fever resolves. And there is serology, that is where you can see the B19V IgM antibodies detection, and treatment is supportive. Now, roseola. Now, this is exanthem subitum or the 6 disease caused by human herpes virus 6 and in children under 3 years of age. This is again a diffuse maculopapular eruption over the trunk and neck, which resolves within 2 days. There's high fever lasting 3 to 4 days, rash after the fever resolves, and febrile seizures may occur. So again, diagnosis, most of these are clinical diagnosis with little by serology. And again, treatment is mainly supportive. Now, infectious mononucleosis. This is again caused by the Epstein-Barr virus in young adults, and this is transmitted by intimate contact with bodily secretion. So what you get is a diffuse maculopapular eruption. This is seen in 5% cases, mainly due to ampicillin. Urticaria and palatal petechiae is the other thing that you need to look on. So these patients are mostly asymptomatic, but there's fatigue and malaise. When there is fever, there can also be pharyngitis and cervical lymphadenopathy, and the atypical lymphocytosis and hepatosplenomegaly. So in the diagnosis, you have a typical peripheral blood lymphocytosis with atypical lymphocytes. This is more than 20%, elevated liver enzymes, and heterophile antibody test, that is positive monospot test or positive Paul Bunnell test. Again, it is supportive, no specific treatment, but for severe complications, you may need to give steroids. So now epidemic, endemic, and scrub typhus doesn't occur so much, but remember that these are caused by the Rickettsial, usually in regions affected by war and disaster and by the human body louse, with an incubation period of 1 to 2 weeks. You have certain symptoms like severe headache, sustained high fever, maculopapular rash, myalgias, photophobia, and so on, and they can have a 10 to 40% mortality. And there's a maculopapular rash which appears in the axilla, spreads to the trunk and then to the extremities. But yes, it spares the face, palms, and soles. There are macule 2 confluent eruptions with petechiae. There's skin necrosis and gangrene with interstitial pneumonia. So again, there's a serology and detection of rickettsia, Kawasaki in a louse or a patient, and cross-adsorption with an indirect fluorescent antibody test. So fortunately, this does not occur so much in India. Treatment is by doxycycline 100 milligram BD, continued 2 to 3 days after the defervescence. Again, endemic typhus, which is due to Rickettsia typhi, exposure to cat or rat fleas containing feces. Again, you see that symptom complex, that is headache, myalgia, arthralgia, nausea, and vomiting, and a maculopapular rash. And treatment is again by doxycycline 100 milligrams BD or by a ciprofloxacin. And scrub typhus, which you see in heavy scrub vegetation or in the wet season due to Orantia shushugamushi. And again, you see the fever, rash, headache, myalgia complex. Of course, this has GIT symptoms too. One interesting thing in the diagnosis is you will see the eschar at the site of the mite bite. And this again could have a mortality as high as 30% if untreated, because it has complications like pneumonitis, encephalitis, and myocarditis. So again, doxycycline 100 milligram BD orally for 7 to 15 days, or azithromycin 500 milligrams OD orally for 3 days, or chloramphenicol 500 milligrams 4 times orally in 7 to 15 days. So we come back to something which is more common, that is dengue fever, which is seen almost once during the year. This is by the dengue virus, and the female Aedes mosquitoes is the vector. So we look at the clinical features. The febrile phase has a sudden onset fever, vomiting and diarrhea, myalgia, gum bleeding and epistaxis, and the maculopapular rash. The critical phase has hypotension and shock with pleural effusion and ascites, bleeding of the gastrointestinal tract, organ impairment, and metabolic acidosis. So these could be causes sometimes for even high mortality. Recovery phase, there is pruritus and there is bradycardia. So the incubation period is 3 to 14 days, and it starts with fluctuating fever, with nausea, vomiting, headache, joint and bone pain, and severe backache. Rash develops on the 3rd to 4th day of fever in half the patients. There may be generalized erythema, but usually the rash is maculopapular or scarletiniform and can be itchy. This does start on the leg, but then spreads on the chest and the trunk, and then to the face, arms, and legs. And the rash fades as the fever subsides, day 7. And it can also pass through a phase of petechiae on the arms and legs due to mild thrombocytopenia. Now, mucosal involvement with oropharyngeal or conjunctival involvement injection is seen in about 30% of the patients. Severe forms are the dengue hemorrhagic fever and dengue shock syndrome, and these occur in hyperendemic areas and multiple serotypes of the virus. The acute high fever is followed by prolonged vasculopathy, in which fluid is lost to tissue spaces, causing hypovolemic shock. There's also a capillary leak which leads to thrombocytopenia. So diagnosis again is by detection of virus by RT-PCR, NS1 antigen, and serology. Management is largely supportive, but there has to be a good fluid management and management of the complications. Another common fever with rash in our Indian setup is the typhoid fever caused by Salmonella typhi, and due to the ingestion of contaminated food or water. This has an incubation period of 10 to 14 days with a prolonged high fever up to 4 weeks. There is relative bradycardia. The rash appears on the first week with arthralgia and myalgia. There can be GI symptoms, splenomegaly, and hepatitis. Now, the rash is very characteristic. What you see is the rose spots seen on the chest and abdomen in the first week with small pale red macules which are blanchable. This can last for about 2 to 3 days. Complications are many, like GI bleeding and perforation, meningitis, GBS, peripheral neuritis, and so on, circulatory collapse and DIC, chronic career, osteomyelitis, endocarditis, and hepatic and splenic abscess. Diagnosis is by leukopenia, raised liver enzymes, blood cultures, Vidal test, typhoid.IgM, and PCR, and treatment is mainly supportive, and antibiotics like ceftriaxone, azithromycin, or cefixime can be given. So this then brings me to infective endocarditis. Now, these are infections caused by Streptococcus viridans or Staphylococcus aureus. What you get is vague constitutional symptom, but there's fever, malaise, fatigue, and a new heart murmur. There are palpable petechiae and splinter hemorrhages in the nail bed lesion. You can see in the second picture, there are splinter hemorrhages. Now, there are the typical Janeway lesions, which are seen on the picture on the right, which are painless macular spots on the palms and soles. And you also have Osler's nodes seen in the first picture, painful purple nodules on pads of fingers and toes. So diagnosis is mainly by ultrasonography and blood culture. Now, next is erythema marginatum, which is also caused in rheumatic fever. This has a typical appearance caused by group A streptococcus in patients with rheumatic fever. The rash is erythematous with annular plaques and papules over the trunk and fever with polyarthralgia, elevated ESR, carditis, polyarthritis, chorea, erythema marginatum, and subcutaneous nodules. And diagnosis is again by the revised Jones criteria. Now, something that we see almost every year is chikungunya fever with the rash. This is again seen in all age groups with an incubation period of 3 to 7 days with clinical features of high-grade fever, arthralgia, myalgia, lymphadenopathy, skin eruptions, conjunctivitis, photophobia, meningeal syndrome, and acute encephalopathy. Now, cutaneous features are seen in 50% of the case, and this is a varied presentation. such as a generalized maculopapular rash, hyperpigmentation, cirrhosis, desquamation of the palms, generalized urticarial lesion, transient nasal erythema, vesiculobullous lesions, vasculitis, EM-like lesions, aphthous ulcers, and oral mucosal pigmentation. What is important is there's a nasal hyperpigmentation or chick sign, which is not seen in any other viral infection. This is quite important in chikungunya fever. So this then brings me to the immune-mediated causes, that is the systemic lupus erythematosus, which we know is an autoimmune multisystem connective tissue disease. We know that there is fever, malaise, anorexia, and nausea, along with musculoskeletal symptoms like arthralgia, myalgias, cardiopulmonary ones like pleurisy, pericarditis, myocarditis, neurological ones like organic brain syndrome, psychosis, and seizures. Renal is nephrotic syndrome and renal failure. And mucocutaneous is a malar or a butterfly rash. You have a fixed erythema over the malar eminences and a discoid rash, which is erythematous raised patches. It has adherent scaling. There's also photosensitivity, or there are oral ulcers. So here you see on the left side the malar rash, which is an erythematous rash seen on the malar prominences, and the discoid rash, which is light pink or nearly whitish. And you see adherent scales, which are there. This is very characteristic. Now, nodular eruptions with fever, this is another kind of eruption, and it's easier to identify. There is disseminated fungal infections, erythema nodosum, but sweet syndrome. But what we'll stick to is erythema nodosum, because we're going to stick to what is happening more in children. So erythema nodosum is definitely an inflammation of the fat cells under the skin, which could occur due to infection with streptococcus, fungi, mycobacteria, or Yersinia, drugs like sulfas, penicillins, and OCPs, sarcoidosis, or it could be just idiopathic. Pathogenesis is a delayed hypersensitivity or immune complex mediated one. Clinical features are fever, weakness, and arthralgia with a tender red nodules on the extensor aspects. You can palpate them. So these are large, violaceous, non-ulcerative, tender subcutaneous nodules. They're very tender. So treatment is self-limiting, resolves in 3 to 6 weeks, but you could give NSAIDs and treat the cause. Now, purpuric eruption is something we often get a call as a dermatologist. Think of the bacterial conditions like acute and chronic meningococcemia, purpura fulminans, disseminated gonococcal infection, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, viral like the viral hemorrhagic fever, Kawasaki virus A9, ecovirus 9, Epstein-Barr virus, and the cytomegalovirus. Now, meningococcemia is something which is important to remember, and there is fever, chills, malaise, myalgias, headaches, nausea, and vomiting. Initially, it's erythematous, maculopapular, and appears first on the wrists and ankles and then becomes palpable petechiae. It spreads to the rest of the body, coalescing into palpable purpura, and diagnosis is by positive culture of skins, blood, or CSF. Treatment, of course, remains with ceftriaxone. And disseminated gonococcal infection, something that we should remember, the triad of tenosynovitis, polyarthritis, and rash. Of course, there are fever, chills, arthralgias, and malaise. What you see are skin lesions on the distal extremities with petechial macules, which progress to form papules and pustules as microabscesses, which later turn to necrotic center. Diagnosis is by cultures of blood, cervical, or urethral secretion. Skin lesions are synovial fluid. Now, this is again a call that we get, that is purpura fulminans. This is an acute, often fatal, thrombotic disorder due to coagulation in small blood vessels within the skin. So cause is again TIC, acute severe sepsis due to Neisseria meningitis, streptococcal pneumonia, and H influenza, and protein C deficiency. What you see is large ecchymosis with sharply irregular shapes evolving into hemorrhagic bullae and then to black necrotic lesions. There is hypotension and features of DIC. So we diagnose this whenever we see purpuric lesions which rapidly progress to necrosis with increased FDP, deranged coagulation profile, and thrombocytopenia. So again, we have to treat whenever we see it, antibiotics, volume expansion, and of course, fresh frozen plasma. So this is seen combined by the pediatrician and the dermatologist. So other common skin rashes with fever, vesicular bullous or pustular eruption. So common ones being varicella, then there's variola, primary herpes infection, disseminated herpes, rickettsial pox, and pseudomonas hot tub folliculitis. Varicella or chicken pox, which is caused due to the varicella zoster virus, commonly in children due to droplet infection or discharge by ruptured lesions. The incubation period is 14 to 21 days, and there's low-grade fever. The rash appears on the trunk on the second day of illness and spreads to the face and limbs. What you see is macules 2 to 3 millimeters evolving to papules, then vesicles on an erythematous base, that is dewdrops on a rose petal. Lesions appear in crops, so they're kind of pleomorphic. You see different stages in the same patient. They are intensely pruritic, very itchy, and hemorrhagic lesions are seen, that is in the immunocompromised. Now again, this can have a lot of complications, especially in the adolescent patient. Herpes zoster, that is due to reactivation of latent infection, myocarditis, hepatitis, interstitial pneumonitis, meningitis, and acute glomerulonephritis. There can be herpes zoster, and diagnosis is mainly clinical, or you could do a Zank smear where you scrape off the roof, of the blister. And in the vesicular fluid, there are inclusion bodies, which can be seen under the microscope, isolation of the virus, and PCR. So treatment is supportive, but then acyclovir can also be given in the patients. Now, primary herpes infection is mainly due to herpes simplex virus 1 and 2, seen in children and young adults for HSV1 and sexually active young adults for HSV2. Incubation period is 1 to 26 days, and it is seen in hepatic gingivostomatitis, herpes labialis, genitalis, encephalitis, and of course, esophagitis, which you can have as complications. In herpes labialis, this you will be seeing very commonly. There are small blisters or cold sores on and around the mouth. There's fever, recurrence, sores heal within 2 to 3 weeks, but the virus remains dormant in the facial nerves. Severe pharyngitis with dysphagia can occur and lymphadenopathy. Then there is herpetic gingivostomatitis, which is similar to labialis with greater severity. Herpes genitalis, when you see clusters of genital sores consisting of inflamed papules and vesicles on the outer surface of the genitals. Diagnosis is mainly clinical with culture of the virus, direct fluorescent antibody, skin biopsy, and PCR. Treatment is again self-limiting, and we do give antivirals. So here again, you can see that is, herpes labialis. And then again, you can see that there is genital herpes and gingivostomatitis, all these conditions that you can see. Now, on the other hand, you can also have confluent, desquamatic or scaling erythemas like scarlet fever, Kawasaki disease, streptococcal toxic shock syndrome, staphylococcal toxic shock syndrome, and staphylococcal scalded skin syndrome. So we'll take up some of these which are common in children. Some of them can occur in adults. So scarlet fever is caused by group A beta hemolytic streptococcus and very rarely by group C or G streptococci, seen mainly in children, and that also under 10 years of age. Now, the transmission is mainly by an aerosol route, but may also spread by direct skin contact and rarely foodborne. Incubation period is 2 to 3 days. The clinical features are sudden onset of fever, headache, malaise, and evidence of tonsillitis, pharyngitis without rhinorrhea or cough. And you can see there's a tender that is superior cervical and tenopathy is commonly present. So when we look at the rash, there is the punctate erythematous rash with characteristic sandpaper feel, which appears on the first or second day of illness on the groin, axilla, and trunk, and then spreads to the extremities, spreading the palms and soles. Pastia's lines are seen in the flexural creases, and facial flushing with circumoral pallor is very characteristic. What you also see is the red papillae on a coated tongue. That's the typical white strawberry tongue, which is seen in the first few days of illness, which later becomes red and glistening, studded with prominent papillae, that is the red strawberry tongue, following resolution of the white coating. The exanthem usually resolves over 4 to 5 days, then it is followed by a thick amount of desquamation of the palms and soles. So again, this is something which is very important and we need to remember this. So here again, you see the strawberry tongue, the peripheral, that is lesions, which you can see again, the erythematous, lesions which you see of the scarlet fever. Now, Kawasaki syndrome, or Kawasaki disease, which the pediatricians know well, which is idiopathic and seen in children under 5 years of age. There is an acute febrile illness with the rash appearing 3 days after the fever, with cervical lymphadenopathy, coronary artery vasculitis, erythema of the lips or oral cavity, and bilateral non-suppurative conjunctivitis. The rash has a diffuse maculopapular erythematous rash, and there is desquamation of saline later. So diagnosis is clinical. Otherwise, you do the 2D echo or coronary angiography, and treatment is intravenous immunoglobulin and corticosteroid. So you can see these pictures. There are signs and symptoms. You see the conjunctivitis. You see the lesions which are there, that is on the mouth, the lips, and the desquamative rash. So another condition which you commonly see in the emergencies is the staphylococcal skin scalded syndrome. The staphylococcal scalded skin syndrome is caused by the Staphylococcus aureus with exotoxins A and B. Commonly, it is seen in neonates and also in adults who are on immunosuppression, renal failure, and lymphoma. What you see is a diffuse, painful erythema with extensive areas of desquamation, perioral crusting and fissuring with irritability, nasal or conjunctival secretion, and thin-walled fluid-filled blisters with a positive for Nikolsky's sign. So diagnosis is, of course, clinical. There's a skin biopsy which can be done, which will show an intraepidermal separation and isolation of Staphylococcus aureus from the blood or the skin. Again, treatment is supportive and you have to give anti-staphylococcal antibiotics, which is very important. So we just need to remember the names of skin eruptions with ulcers or eschars and fever. So it's the Rickettsial infections, tularemia, and anthrax. And then I come to another very important heading, and that is drug rash. So most drug-induced cutaneous reactions are mild and disappear when the offending drug is withdrawn. This is diagnosed mainly from the medical history and clinical examination. It can be maculopapular morbilliform eruptions, which are most common. Urticaria is the next common one, and less common ones are anaphylaxis, Stevens-Johnson syndrome, or toxic epidermal necrolysis. So the morbilliform or maculopapular eruptions here, they appear on the trunk and spread to extremity. So this is the other way around. It spreads from the trunk. This may be associated with moderate to severe pruritus and fever, and they are mediated by T cells and typically delayed in onset, first occurring between 2 and 14 days of exposure to drugs. And rarely these rashes can progress to DRESS or SJS. This brings me to DRESS. This is a drug reaction with eosinophilia and systemic symptoms caused by exposure to certain drugs that causes rash fever inflammation of internal organs, lymphadenopathy, and characteristic hematological abnormalities such as eosinophilia, thrombocytopenia, and atypical lymphocytosis. The syndrome carries about a 10% mortality. The symptoms usually begin several weeks, that is 2 to 6 weeks after exposure to the offending drugs. So these are some of the drugs associated with stress, usually the anticonvulsants like phenytoin, carbamazepine, phenobarbital, lamotrigine. Then you have the antibiotics, you have sulfasalazine, celecoxib. Then you also have dapsone, ibuprofen, and many other drugs which are responsible for this. So we know that it's a maculopapular eruption progressing to exfoliative erythroderma and profound edema, and pustules may appear. So you have an edibatous appearance also. Treatment, which is very important, is immediate discontinuation of the suspected drug, supportive care, and definitely corticosteroids. So another characteristic one, a drug rash, is erythema multiforme, which is acute self-limiting recurring hypersensitivity reaction. This is associated with drugs and infection. The exact cause is unknown. The disorder may start with damage to the blood vessels of the skin, that is followed by damage to skin tissues, and it is mainly self-limiting. So again, drugs can be sulfonamides, penicillin, macrolides, barbiturates, allopurinol, or it can be due to infections like herpes simplex, mycoplasma pneumoniae, or it can be idiopathic. So in the clinical features, there's an acute presentation with fever, there's itching and burning at the site of eruption. Lesions could be maculopapular evolving to plaques. And there are target lesions when there's a central erythema surrounded by area of clearing and another rim of erythema. This is symmetric on extremities, that is knees, elbows, palms, soles, and spread centripetally. And there is erythema major, multiforme major, with extensive lesions with vesicles involving the mucous membranes. So this is SJS and toxic epidermal necrolysis, which are two forms of life-threatening skin condition, which is caused by a reaction to drugs and characterized by blisters and epidermal detachment resulting from epidermal necrosis in the absence of substantial dermal inflammation. So a great deal of skin is lost in these. Again, this is mostly due to drugs, that is sulfonamides, phenytoin, lamotrigine, allopurinol, nevirapine, phenobarbital, carbamazepine, and other drugs. So you can have fever which is more than 39 degrees Celsius, painful skin lesions, sore throat, and conjunctivitis, erythematous and purpuric macules, sometimes target lesions, diffuse erythema progressing to bullae with epidermal necrosis and sloughing, mucosal involvement, Nikolsky's sign, and we call it SJS when there is less than 10% epidermal necrosis and 10 when it is more than 30% epidermal necrosis. Now, these are just like burns patients, if you look, and this is a patient of Stevens-Johnson syndrome when you have areas which you can make out of normal looking skin. There is conjunctivitis, involvement of the oral mucosa, and it is detached or detachable skin. And you can see on the right side, this is toxic epidermal necrolysis. The skin just peels off like a burns patient. So it's to be treated like a burns patient. With early diagnosis, immediate discontinuation of suspected drug, supportive therapy, transport to burn units or intensive care units, and adequate hydration. We do manage in the skin wards with the help of the pediatrician. So this brings me to an important question. What is the difference, between the viral exanthem and drug eruption, because you have fever and rash in both? Remember that in a viral exanthem, the location is more of face, hands, feet, and buttocks, whereas drug eruption starts more from the trunk, then goes to the proximal extremities and folds. Evolution of a viral exanthem is more on the face, spreads as a snowfall, and the color is bright red as opposed to the dusky red in drug eruption. Prodrome is usually present in a viral exanthem, and Pruritus can also be mild, but in a drug eruption, it is always intense. Enanthem is usually present in a viral exanthem, but it's rare in a drug eruption. The other signs in viral exanthem are fever and lymphadenopathy, but in drug eruption, it's a low-grade fever. Now, recently with COVID-19 around in different waves, COVID-19 has been fever, and there's been a rash of different types which evolved during the COVID-19 waves. You can either see the urticarial rash, vesicular one, livedo-reticularis, petechial, morbilliform, or even the acral ischemia. So you see different types of rashes. So how would you approach such a patient, a child with fever and rash? Obtain a thorough history, look at the characteristic of the rash, assess for life-threatening illness, consider differential diagnosis, obtain diagnostic studies if needed, and determine need for empiric antimicrobial therapy. So this may have to be started really quickly. And one example of each, that is fever with rash, and you can see it also in histopathology. And if you see the central maculopapular, common ones like measles, peripheral maculopapular like the secondary syphilis, drug eruption, confluent desquamatic like the SJS 10, vesiculobullous or pustular like SJS 10 again, or herpes simplex virus, varicella zoster, purpuric like you can see purpura fulminans, nodular, the important one here is erythema nodosum, Ishkar, again, it can just be due to insect bite or ecthyma. You may have to determine that. And broadly speaking, approach to fever with rash, it can either be infectious, where you have viral infections. Look at important and common ones like measles, rubella, roseola, erythema infectiosum, Epstein-Barr virus, and dengue, and bacterial infections like scarlet fever and rickettsial ones, which occur in many other countries. Non-infectious ones like rheumatologic disorders, that is acute rheumatic fever, Kawasaki disease, and Hinoch-Schollen's purpura, and medication reactions like erythema multiforme and the Stevens-Johnson syndrome. So we'll have a quick look at the algorithm. In the maculopapular rash, if there's a central distribution, if there is fever, then you look for a viral exanthem. If fever is less or not there, look for a drug reaction, even for Pityriasis rosea Herald's patch. In peripheral distribution, look for fever, or is the patient toxic ill? If yes, look for target lesions. If yes, look for Stevens-Johnson syndrome or erythema multiforme, or even Lyme's disease. If not, then look for meningococcemia, Rocky Mountain spotted fever, or even syphilis, which is there. And lesion distribution, which is there, which can occur in flexor, extensor. And in the flexor, you have to look for scabies, eczema. And in extensors, again, you have to look for diseases like psoriasis. So when you look at the vesiculobullous rash, if it is in a febrile patient, look for a diffuse distribution. Then you look for varicella, smallpox, which doesn't occur now, but you have diseases which may resemble it. Disseminated gonococcal disease and purpura fulminans and DIC. Localized distribution like necrotizing fasciitis, hand, foot, and mouth disease. In an afebrile patient, there's diffuse distribution like bullous pemphigoid, pemphigus vulgaris, which comes to us, the dermatologist, and localized ones like contact dermatitis and herpes, and even discoid eczema. We just need to remember the fever with rash and arthritis. So look for chronic meningococcemia, hepatitis B or C out of the important ones, rheumatic fever, endocarditis and HIV, non-infectious ones like juvenile rheumatoid arthritis, SLE, serum sickness, and rheumatoid arthritis. And some of the important life-threatening infectious causes of fever with rash, just to remember the names: meningococcemia, important in our setup, the Vibrio, toxic shock syndrome, necrotizing fasciitis, typhoid fever, viral hemorrhagic fever, and the acute endocarditis, which we need to remember. Others which we don't see so much here, but in other places, that is Rocky Mountain spotted fever, leukosis, and also certain other diseases due to gram-negative bacilli. But we do need to bear it in mind. So before I end, I'd like to say that in most of the causes of fever with rash, they are self-limiting, and if we keep a careful watch and supportive treatment, they do subside with time. So it does need a combined approach of the pediatrician and the dermatologist. But you do need to look out for toxicity, signs of toxicity, systemic involvement, and that is when it is very important to treat rapidly, maybe with antibiotics and other supportive treatment. So with that, thank you so much, and I hope that you've got some good information listening to this lecture. Thank you very much.
Thank you, ma'am, for a wonderful presentation. We have Dr. Amit Meena, Senior Resident at Lady Hardinge Medical College and Kawasaki Saran Children's Hospital, and Dr. Arpita Chattopadhyay. She is Professor of Pediatrics at Chacha Nehru Bal Chikitsahalaya. We also welcome Dr. Alok Bhandari, sir. House is open for question and answers. Dr. Amit, do you have any questions? Dr. Arpita will be answering.
No, sir, I don't have any questions, sir.
Okay.
Yes.
There are a few questions, ma'am. Scrub typhus is not uncommon. What is your opinion? How many cases you see, ma'am, of scrub typhus regularly in the Dr. Arpita? Please unmute yourself. Please unmute.
Okay.
Yes.
So we have seen a lot of scrub typhus in our ICU this season. Particularly, there was a very heavy rainy spell this year in the June, July. So we had around 9. After that rainy spell, we had about 9 patients of scrub typhus admitted in the ICU with myocarditis, bilateral pleural effusion. But that is in the acute setting. I would like inputs if there were more such cases in the OPD setting or in the wards.
Many patients with prolonged fever and rash, they're coming in OPD also.
Yes. Okay.
As we recently, mefenamic acid was in news for the DRESS syndrome. So drug rash can be there. And Dr. Amit, if a patient has taken drug a long time back, say 1 or 2 months back, will there still be a fever or just rash?
Sir, hello?
Yes.
Yeah, so can you repeat the question?
There was a question about drug history of 60 days for drug rash.
Yes, sir.
So once the patient has taken any drug, now the rash has happened, will there be a fever or not?
Sir, usually fever does not occur, sir. Rash may appear, sir, actually.
Okay.
So only rash may happen. So, sir, we take the history of around 60 days. If the patient has taken drug in that day, it may occur, sir. Actually, it depends on the half-life of the drug. But if the patient has taken any drug before 60 days, then it usually does not occur. And, sir, most of the rash occurs within 1 to 3 weeks, sir, in most of the cases.
Thank you. And in our MBBS times, you used to read that we do not see scarlet fever, but we still see some cases of scarlet fever because it was said that due to dark skin in Indians, we are not able to appreciate it. But I think it is visible. Sometimes patients do come with the scarlet fever kind of rash also. Have you seen any, ma'am, Dr. Arpita?
I have seen very rarely once or twice in my OPD.
Because these patients tend to come with discoloration of skin after 1 or 2 weeks.
Doctor, there are questions. There are questions. Please take them.
Hanji. How to identify erythema marginatum?
Hello.
Yeah.
Yes, sir. So the erythema marginatum rash usually initially start as a macule or a papule. Then, sir, it spreads in a centripetal fashion. Centripetal means, sir, that it basically appears as an annular. So there is central clearing in the center, and in the periphery it is erythematous. And, sir, it rapidly spreads actually. And the rash fades within hours, and then it reappears, then it fades, and then it reappears, sir. So it's basically a vanishing rash, sir. Waxing and waning course, sir, it has. And the lesion is usually single, and it typically occurs at the trunk, sir.
Okay, thank you.
Yes.
Dr. Arpita, in cases of varicella, do we need to treat all the cases or only a few cases?
Usually, we don't treat the one cases which have multi-system involvement because it subsides on its own. But if we see that a patient has severe manifestations, extensive rash that leads to decrease in oral intake, or there is a high vesicular rash, and then there is pneumonitis. If there is associated multi-system involvement, then definitely we should treat with acyclovir. But otherwise, most of the time, it subsides on its own. Also, if there is very high-grade fever that is persisting, there is secondary bacterial infection, then we may need to even give antibiotics.
So do we treat all children with the varicella less than 1 year of age with acyclovir or more than 10 years because disease is more likely to be severe in these cases?
Sir,
Actually, sir.
Yes.
Please carry
Yes,
on.
Dr. Amit.
Okay. Sir, actually, in our setting, sir, we do not treat all cases of varicella, sir, until unless the patient is immunocompromised or in the neonates. So we need to give the treatment for the varicella. And in neonates and immunocompromised, we usually give, sir, IV treatment. Because there is risk of complication. And in the, sir, infants, we usually don't treat, sir. So and sir, up to 12 years of age, we usually do not give acyclovir unless the patient is immunocompromised or if there is systemic involvement, like if there is CNS involvement or if there is pneumonitis or hepatitis. Because in this age group, the children usually develops the immunity, and so we want the rest to get resolved itself.
The dose of acyclovir is 20 milligram per kg per day. It has to be given in 5 divided doses.
Sir, actually, yes, sir, in the 5 divided dose, and the dose is, sir, 10 to 15 milligram per kg per dose, sir.
Okay.
Yes, sir.
Is there any drug called famiciclovir for chickenpox?
Sir, most of the cases resolved by the sir, in the children we usually don't treat, and if we need to give, then we give the, sir, acyclovir, or if acyclovir is not indicated, then we can give the, sir, valcyclovir, sir. Because the, sir, dosing of the valcyclovir is less, like the acyclovir is given 3 times and valcyclovir is given, sir, 1 time a day. So we can give the valcyclovir, or there is no role of famcyclovir, sir. And most of the cases they resolve itself, and if they do not resolve, and if we give acyclovir, then most of the cases will resolve. So we have, sir, I have never given the famcyclovir, and I don't think it has any role, sir.
Ma'am, Dr. Arpita, do you use azithromycin or doxycycline for typhus and Rickettsial, and the dosage is?
So we use doxycycline. The reason is that it depends. So if we have a patient who has severe pediatric ARDS, which is one of the common manifestations of scrub typhus, then we give azithromycin because it also covers scrub typhus along with atypical infection. If, however, we have a patient who has mild pneumonitis, liver involvement, kidney involvement, so we can also suspect and there is a presence of rash. So with scrub typhus, if leptospira is also in our diagnosis, then we give doxycycline. So it depends upon how the patient has presented. If severe pediatric ARDS is the main manifestation of scrub, then we prefer azithromycin. Otherwise, if there is just mild pneumonitis and other organ like kidney, liver involvement, then we prefer doxy, because both of these drugs have got different spectrum.
Varicella. There's a comment that in varicella, children more than 12 years, because they are likely to have more severe disease. So you can use acyclovir if they have presented to you at an early stage, because acyclovir doesn't affect if the patient has presented after 3 days of the rashes. Is that right, ma'am? Dr. Arpita, if the patient has presented with the chickenpox rash after 3 days of illness, will the acyclovir be still effective?
Sir, again, as I said, if there is, even after 3 days of rash, if there is involvement, if the patient is immunocompromised, or if there is encephalitis, pneumonitis, then acyclovir has a role. Otherwise, we will not give acyclovir.
There is one question. Recently, we got a case of 6-year-old female child with maculopapular rash on day 2 of fever. Started on face, no cough, cold, conjunctivitis. Rash appears to be sandpaper, no other symptoms, clinical clues. There is a diagnostic dilemma in OPD saying Scarlet or Measles. So, do the rash appear early in measles or after normally 4 days of fever?
I'm not able to get the question.
There was a case in the OPD, one of the delegates has asked, maculopapular rash on day 2 of fever. On the face, no other associated cough, cold, conjunctivitis. Rash appears to be sandpaper. What is more likely diagnosed?
So we have to again do a thorough examination of the throat, whether there is any pharyngitis, and whether there is a Pastia's lines, or whether there is perioral sparing. Also, whether the patient is immunized or not immunized. And depending upon that, if the patient has measles, then we will not treat anything. And if the patient is suspected of scarlet fever, we will start amoxicillin after taking a throat swab.
Can it be infectious mononucleosis?
Sir, infectious mononucleosis will be associated with other signs such as atypical lymphocytosis, presence of huge splenomegaly. The patient is going to be much more toxic than a patient of scarlet fever in cases of infectious mononucleosis. Also, it is not very, just like scarlet fever, infectious mononucleosis would not be the first differential. We'd first try to rule out the more common causes. We have to ask them whether the rash worsened after taking ampicillin or not, which is more likely in a patient with infectious mononucleosis. So again, the whole diagnosis is an integrated approach where we have to take a good history, good thorough clinical examination to rule out presence of a huge tender spleen, a blood examination where we have to rule out atypical lymphocytosis, and then we'll have to plan whether to do a throat swab or an ASO titer, or whether to go for the Paul Bunnell test, and so on and so forth.
Dr. Anuradha has asked, can we get herpes zoster immunized with chickenpox adolescents? After chickenpox vaccination, is there a possibility to get herpes zoster in adolescents?
I won't be able to answer that question. I think
though herpes zoster can happen in adults after even vaccinated adults, the chances are very less as compared to a natural infection. And more questions. I think most of the questions have been answered. Erythema multiforme versus marginatum difference, is it just more in number or varied shapes? Dr. Amit?
Yes, sir. Sir, basically the erythema marginatum is, sir, usually a single lesion, and it is basically we have a central clearing and the periphery is erythematous. And sir, while in the case of the erythema multiforme, sir, we typically get the target lesions. So in the target lesions, sir, in the center, so there are 3 rims are there, sir. So basically in the center, we get a purpuric lesion or a papule or a vesicle, and which is surrounded by some, sir, erythema. And then in the center, sorry, sir, in the center, sir, there is a papule or a vesicle which is surrounded by the purpuric lesion, and in the periphery there is a erythematous ring, sir. So these are basically the typical lesion of the erythema multiforme. Second thing is that the erythema multiforme lesions are, sir, very multiple in number, and it typically starts with the hands and the feet, sir. So typically involve the acral areas, and sir, if the erythema multiforme lesions usually occur on the face also, and sometimes it involves the mucosa also. So sir, in the mucosa it also present with the ulcer, sir. So there are these basically 3 differences are there, sir. First is the morphology. In the erythema multiforme we get the target or the targetoid lesions. Second, these are multiple in number. Third, they typically involve the peripheral areas like the hands and the feet, or the palms and the soles and face, and it also involves the mucosa, sir. While the erythema marginatum is usually a single lesion. It is basically annular lesion with central clearing and peripheral erythematous. And sir, it does not involve the mucosa. And the, sir, rash is waxing and waning in case of the erythema marginatum, sir.
Thank you. Dr. Rapita, what is the minimum age to use doxycycline?
Actually, initially there were concerns that it leads to pigmentation of teeth. But we have used even in infant, if there is severe manifestations of scrub, although a scrub and leptospira does not present in a very young age, but we have used in infants and it does not, and we have followed up these patients, it does not really lead to any teeth staining and so on.
That happens more with tetracycline rather.
Yes, so we can use even in infants, doxycycline.
Ma'am, how commonly are we getting Kawasaki nowadays? Is there any increase after the COVID?
There was a phase particularly after the first wave, when we had many patients with Kawasaki-like disease, which was eventually many of them were cases of MISC, and also after the second wave. But now with the improvement in vaccination, there has been of course, very few cases of MISC, and somehow we are observing that even the cases of Kawasaki disease have decreased. We had more cases in the year 2021, 2022, but in 2023, the year that has gone by, in our ICU, we had only 1 or 2 patients of Kawasaki disease, and the numbers were much more in the year of 2021 and 2022.
Thank you. This question, how to treat intense pain in herpes. I think this is a difficult pain to treat. I'll request everyone to take, whoever is more than 50 years of age, herpes zoster vaccine. Prevention is always better than the cure. So most of the questions are answered. So thank you very much. Thank you, Dr. Amit. Thank you, Dr. Arpita ma'am, for your participation. And